morning, everyone. I'll be presenting on a study on graft junction and astigmatism by AIOC2022 and Orbscan after penetrating keratoplasty. I have no financial interest with the presented material. Introduction. Corneal blindness is one of the leading causes of reversible blindness. It can be managed by transplantation of a healthy cornea. Cornea transplantation has high success rate, but all are not achieving 6/6 vision because of post-operative astigmatism, which arises due to sutures, graft host malapposition, and so on. It needs to be assessed at the earliest. Graft host junction is visualized in a slit lamp, but the posterior surface can only be evaluated by an AIOC2022. Hence, AIOC2022 examination of graft host junction to look for overriding steps and gaps is an important aspect in post-operative evaluation of post-penetrating keratoplasty patients. Orbscan helps in assessing corneal astigmatism following the surgery. Aims of the study: to evaluate graft host junction following penetrating keratoplasty and to determine the relationship between graft host apposition and post-operative astigmatism. This is a prospective exploratory study conducted over 18 months. Sampling technique used was purposive sampling. 20 patients were included in the study. Inclusion criteria included corneal dystrophies, keratoconus, corneal ulcers, pseudophakic bullous keratopathy, and so on. And exclusion criteria: any posterior segment pathologies, vascularized cornea, limbal stem cell deficiency, or difficulty in getting the images due to poor resolution due to corneal opacities. Statistical methods: we use MS Excel 2007, and methods used were ANOVA test and paired t-test. And we have, after penetrating keratoplasty, patients were followed up at 6 weeks for AIOC2022 and Orbscan. This is the AIOC2022 evaluation. At 6 weeks, AIOC2022 vector was placed at 4 diagonal points: 45 degree, 90 degree, 180 degree, and 315 degrees. And 4 optical sections were studied 45 degrees apart, and 8 junctions were studied. And we have looked for overriding step and gap. Figure 1 shows a well-opposed graft host junction. Figure 2 shows a graft host junction with a step, and figure 3 is showing a gap at the junction. The amount of overriding was measured using the AIOC2022 tool, and when the vector was placed at 90 and 45 and 315 degree, superior and inferior junctions were studied. When it was placed at 180 degree, temporal and nasal were studied. Central corneal thickness was also measured. Orbscan evaluation: we have measured horizontal and vertical corneal curvatures, cylinder and the axis, and CCT was also measured. And descriptive statistics and comparative studies were performed for AIOC2022 and Orbscan values. Results of my study: 13 were males and 7 were females. 11 were right eye, 9 left eye. 22 to 76 was the age range. Common indication for the surgery was infected corneal ulcers. Others were pseudophakic bullous keratopathy, corneal opacity, and so on. And this graph 1 shows number of graft steps at 45, 90, and 315 degree and 180 degree. As we can see, there are more graft steps in the superiorly. Graph 2 shows gap junctions at 45, 90, and 315 degree and 180 degrees. And gap junctions are positively correlated with K1, K2, and Ka Orbscan values, implying an increase in gap junctions are associated with increased K1 and K2. And gap junctions and steps showed a statistically significant difference with the cylinder at 7 mm, thus showing internal graft malappositions causing astigmatism. Discussion. Kesaman et al. Showed malappositions are common in the internal graft host junction, which was associated with astigmatism, myopia, and increased IOP. In our study, 42.5% showed malappositions in the form of gaps or steps or both. It was found to be associated with astigmatism. Steps with cylinder showing a statistical difference, which is significant, P is equal to 0.001, and gap junctions and cylinder also showed statistical significant difference, P is equal to 0.0005. And 180 degree temporal and 315 degree inferiorly showed highest number of well-opposed junctions, whereas 45 degree superior and 90 degree superior showed lowest number of well-opposed junctions, suggesting better suturing techniques in the superior quadrant. And many of the previous studies used keratometric astigmatism, where measurements were done at 3 mm zone, where we have studied at 7 mm using Orbscan. So this gives a more accurate correlation with the graft-ose malposition, thus measuring central corneal astigmatism. Conclusion of my study, it showed statistical significant results, ASOCT with ASOCT measurements of gaps and steps with the Orbscan analysis. Hence, ASOCT is a valuable tool in assessing internal graft-host interface in addition to Orbscan analysis. Recommendations: identification and proper approximation of gap junctions and steps during surgery help in reducing surgically induced astigmatism, and studies in future are needed on large scale to correlate with different diagnoses and different alignment patterns, and to determine other factors contributing postoperative astigmatism like graft oversize and suturing techniques, and to quantify amount of astigmatism caused by certain amount of misalignment, and to study more optical sections in ASOCT to avoid chances of missing any malpositions. Limitations of study: posterior corneal elevation was not studied. In ASOCT, we studied 4 sections, but some may be missed because we suggest more sections to be studied. Our sample size was small. A large scale study will help a better understanding of the reasons of postoperative astigmatism. These are my references. Thank you.
So you mentioned in your study that malposition can lead to raised intraocular pressure. So what do you feel, what might be the reason for this?
Ma'am, any
how much oversizing did you do for your grafts?
Ma'am?
How much oversizing?
Ma'am, 0.25 or 0.5.
So do you think that changing the oversizing of graft might lead to change in intraocular pressures?
Yes, ma'am. Bigger the size, there are more chances of increase in IOP following the surgery.
So if you increase the oversizing, that will lead to?
Maybe, ma'am, it can more astigmatism is more.
No, what about IOP? What will it do to IOP?
IOP.
How many patients had raised IOP in your study?
Ma'am, IOP was
Not
studied.
you mentioned, na? And that is okay.